Thanks, John. We've got a lot of mentors in our lives, and John Fry has been one of mine. When I was at the University of New Mexico, he would come down from Santa Fe and or Abiquiu and do a faculty whispering session in my living room. And he would pick a topic, and we would have deep, meaningful conversations. And so thanks, John, for all you've done for us, this department and other departments. Really a big presence in our lives. All right, we have a room full of legends tonight. And one of my favorite is our Gene and Linda Farley Annual Professor, Art Kaufman. Art is truly a living legend. In fact, what was it, about 4 years ago, he actually participated in a UNM celebration of his life as a living legend. Which isn't that beautiful, right? I mean, we should all have a funeral while we're alive. I mean, that would be a lot more fun. But Art is one of those rare breeds who mixes kindness, excellence, compassion, and encourages us to always push the envelope a little bit more. And I pride this department, this history of the department, the whole field of being somewhat stubborn, kind advocates for social justice. That's Art Kaufman. He is the only faculty at the University of New Mexico who's been accepted into the National Academies of Sciences. I think we have more than that in our own department. Mike, you're in that group. We have others here. But Art and his work has been the only one accepted to that prestigious group, mainly due to a lot of the work he's done. He, before we even had that phrase roll off our tongue of social determinants of health, he was talking about it. He created this beautiful hub and spoke model to incorporate community health workers from the community, representing the community, into the clinics throughout New Mexico. He was also one of the pioneers in problem-based learning. So you may not all know what problem-based learning is. We used to learn by heart and lung. And then Art and his buddies decided, is that the best way to learn? They said, no, we're solving problems all day. So let's teach that. So if you have knee pain, let's do the exam. Let's figure out the therapy. Let's make it practical. He's a kind rebel who isn't afraid to push the boundaries. And so I'm so happy that we have a chance for him to share his wisdom with us. Please help me welcome Art Kaufman as our Farley lecturer.
So I wanted to talk about something that we all share, this whole idea of a social mission for an academic health center. And it's something that's so important. And from my years of trying to make institutional change at New Mexico, it doesn't work to be a smartass and to tell everyone else what they should be doing because you got the best. Never. You're excluded. You have to listen to other people, and change has to occur more slowly. And it takes a long time. You have to be there through thick and thin. This issue of social mission, I've worked with Fitzmullen and others to design this beyond Flexner, and it was very interesting because I didn't even know these details, but Flexner Reform started with his publication 1910, and it was, I read snippets of it. I think most people don't read it, and I agree, but I did read these snippets. And one of the things that happened is there was 188, mostly proprietary medical schools, and the beauty of it is he made it more scientific, tried to link them more with academic centers, and that was a positive step. They lost about 42% of the medical schools in the United States because of those reforms, directly and indirectly. Big change. What I didn't know, and this was one of the genesis of the Beyond Flexner movement, was there were 3 women's medical colleges, and he wanted to close them all because women, they didn't have the temperament to be doctors, and there wasn't any need. People weren't crying to have women doctors, so he dismissed them. There were 7 black medical schools, and 5 of them closed. He only recommended they stay 2 open because he did recognize African Americans may want to see African American doctors, but not in the general sense. He felt that the African American population was a bit low on hygiene and Slavic, so he didn't want those doctors from those 2 medical schools to become surgeons. They should become hygienists. This is the background. On the left side, there's Virchow, and so the great pathologist had a different view. And if you read his writings, they're very much social. He believed medicine is a social science and it's a political science. And so these are the 2 kind of backgrounds that kind of lead us to where we are now, because I thought Virchow was closer to what we're trying to do today than a lot of other folks we hear about. So I'm going to give you just a kind of a data fragment, which means a lot in New Mexico. And if you look at the endpoint of deaths from diabetes, and you look at which population in New Mexico that gets the best screening and treatment for that disease, it's the Native American population. Incredible federal and state budgets, public health interventions, fantastic. Except it has the highest death rate from that disease. Best screening and treatment, worst outcomes. As a matter of fact, if you look at most reservations in New Mexico, they have a dialysis unit for uncontrolled diabetes. So why is that? And it's because as good as the healthcare system may be, it can't make up for years and decades of poor housing, low educational attainment, low income, social exclusion, marginalization, racism, all the toxic stresses that impinge on our health. There was a study done by the Institute for Public Health, and they ranked every single state in the United States in terms of the burden of adverse social determinants. The further down you go, the higher the burden. So New Mexico ranks last, highest burden. Well, there's a lot of poverty. And the problem is, if you look at this data, you know that if you're going to improve the health of your patients and your communities, you cannot ignore social determinants. That's it. That's the message. And to make it even more stark, and you know, there's all this data that 90% of the healthcare dollar goes into the healthcare system, which only affects about 10% of what makes us healthy or leads to death. 10%. But the social determinants are within lifestyle and environment, and that affects over 60% of health. 60%. But it only gets 3% of the U.S. healthcare dollar. So all the things I want to talk about is how on earth do you reallocate dollars upstream? Because very rarely are you going to have a healthcare system going to dole out dollars elsewhere. Everyone's got no margin, no mission statement all over the place. So how do we actually do that? What we did is we put together with community health worker groups we had, what are the top adverse social determinants that you have? So it had lots of them: food, housing, nutrition. But we then gave it to 50,000 patients at the university and First Choice, the FQHC. And what we found was that half the patients had at least one adverse social determinant, and half of those had more than one, some 5 or 6. But what's unique is we didn't know about that. We don't ask those questions. Now, all the doctors in the room, we get respiratory rates in our patients. There is an MA sitting there counting someone's respirations for 15 seconds and multiplying by 4. I haven't used that in 50 years. But it's there. Someone's taken the... Now, if I had this, I could really act. Okay? Here's the disconnect. So there was a study done by Robert Wood Johnson Foundation called Healthcare's Blind Side, and they asked 1,000 physicians, what is the importance of all these social factors compared to medical things you deal with? 80% said they're about equal. 80% said, however, I can't do anything about them. My health system doesn't give me any support. And the other thing is it's not just poor people. All of us have it. And we have a colleague who got divorced. She gained 50 pounds and pointed to her health and said, adverse social determinants. Absolutely. All of us have parts of this. So this is a bit of a diversion, but I noticed that our clinics in the last 10 or 15 years have been transformed. There's a couple doctors, a couple nurses, but there's a sea of medical assistants. They're all over the place, medical assistants. And they have to actually screen patients for these, so we got to really train them. But I wanted to know, how do you become a medical assistant? You know, naive me. Working for years with them, I didn't know anything about them. They all have to graduate from these Betsy DeVos private colleges. $15,000 tuition that they all have to take loans for and pay back over years. They're the lowest paid of any health worker in our healthcare team. And they have the highest burden to income. So we actually set up a program with our local community college. We train them almost for free. And it's very important because that means they're not bouncing from job to job to get another 50 cent per hour raise. The payback is horrible debt. So one of the sides. The other was what Dave said was right. There's community health workers every place. Nothing innovative that we did except we put them in the middle of all our clinics because of the data showing that you had to have somebody dealing with the adverse social determinants. And they're very popular. They're one of the few people in the clinic who take things off our plate. The patient has bed bugs. Where do we get a mattress? She'll find out where to get the mattress. They go to the income support division, keep people in their homes, make sure their car isn't repossessed. They're on the front line doing this. I don't know how they do it. They don't even ask. Community health workers. So now we have this team, a doc, an MA, community health workers. MAs do the screening. Those that are positive go to the community health worker. All right. The outcome has been dramatic, and this is our data, but also other data, showing there's a significant reduction in expenditures, lower admissions for primary care sensitive diagnoses, less drug costs, less ER visits, all of that. It's all known. But here's the problem. If you look at how, let's say Medicaid, for us, everything is Medicaid because it's like half the state. We're an expansion state. And because we're poor, half the state. So every enrollee in Medicaid has to get a health risk assessment. It takes maybe about a half hour, not a long time. And that health risk assessment puts them in three categories. They're either tip-top, top 5% hot spotters, or they're, they got a lot of chronic diseases, not doing that great, but not that bad, not being hospitalized again and again, not hitting the ERs again and again. That's that next level too. The big group is the 85% of level 1. But we know from our data, level 1, they've got a huge percentage that have adverse social determinants. So unless you can intervene at 1, you're not going to stop people from getting to 2 to 3. So we have to step back and take a public health approach. It can't just be the hotspotters. And I think many of you read Brenner's, or the evaluation of Brenner's Camden study in the New England Journal. And he did incredible work, but he didn't save any money because it's very, very costly if you're going to just focus on the most at-risk, most severe, homeless, draining wounds. So you have to think more broadly about the whole population with whom you're going to intervene. A big break came a couple months ago, hot off the press. So we're doing our social determinants. We got the state Medicaid to require every managed care organization has to put money into hiring community health workers. They got it. Social determinants are going to be addressed. It's not going to be theoretical. They have to address it. We had did you get the Accountable Health Communities grant? The Accountable Health Communities AHC? University of Wisconsin? No, okay. So CMS put out this massive grant. It's like 32 sites around the United States. And they were like counties. So ours was Bernalillo County. And each county had to screen, that is, the recipients. And for us, it was Presbyterian, a big hospital, and the university. Screen 75,000 Medicare and Medicaid patients for social determinants, and then refer them. And the question was, they were going to do this national study. Can CMS show that you can decrease costs and increase outcome, improve outcome? And the answer was, yeah, it did. So they just came out with this. Every hospital in the United States in 2023 has to screen for at least 5 social determinants: housing, food, transportation, utilities, and safety, of inpatient adults. That's all. Now we think the next step in the next year is now do something about it. So this is rather remarkable. Now they're using the data from these big studies to show you're going to have to screen for social determinants. Big, it's national. Everyone's going to have to do it. Our hospital said, well, wait a minute, we're shovel ready. They'd rather give us the money to do this work than have to concoct their own innovation. So, hey man, we're on a roll here. And again, you have to wait long enough, the 30, 40 years to get to this point. One of the things when you look at your electronic health record, I'm puzzled by this. I get my respiratory rate, blood pressure, weight, I got all the basic vital signs data. But I wanted to make sure that you could actually put the social determinants right next to the vital signs. Simple idea. So Cerner, that's our partner that just got consumed by Oracle, they came up with this idea. We're still playing with it, that every patient, if they have an abnormality, let's say in this person, this guy's got legal problems, they can't get child care, they don't have enough income. Okay, that's the diagnosis. Now, the next time they visit, has it been addressed? So our feet are held to the fire, just like with hypertension or a BMI that's too high, we have to do something about it. This is important to me because, I don't know about you, when I drive down a street and I see a stop sign, not a stop sign, just a sign, 35 miles an hour, I zip by at 45, I don't know. But when that damn thing goes flashing at you, that you're going 1 mile an hour, I put on the brake immediately, right? So that's what I think we have to do. It has to be that visible right in front of you where everyone is saying, oh, you didn't do anything about the legal problem, what are you going to do? So this is what we're working on now. There are 2 groups of people in the community who help us as well. And we built this up, trained these 2 groups. The first one are health extension. And University of Wisconsin is both a land grant and a flagship, right? Yeah. We have 2 separate ones. So we play each other football, basketball. But the communities really love their ag extension agents. They don't know us. We sit in Albuquerque. So we had to emulate agriculture. And we went down there for a full day. They did cooperative extension 101. We learned everything about extension. Went back to the time of Lincoln. Every state had a college that would have to give education around agriculture, increase the crop yields, decrease, tainted food, all that, getting kids through school, 4-H clubs. So we did that, and we have these folks, now there's 15 of them all around the state. Every year we get 2 or 3 more. And then we have the community health workers. So not only are they in the hospitals and now in the clinics, but also they're embedded in a lot of social agencies. So there's a network that they can call to each other very quickly to get people the resources they need in whatever particular social determinant problem they have. So this is how we're building this. This is just a picture of, this is our vision. We're halfway there. We should have a health extension agent, every county, all the large tribal communities. The other thing that happened was, The other thing that happened was we decided to train all health providers, all students, all residents, all faculty, all staff that take care of patients in social determinants. So we just got a grant to actually put this together, 5 modules, try to do it in several hours, because it's very hard to get anything in any college. Like, oh, we like to do it, but we have accreditation, we can't possibly. Oh, no. It's online, or you can have small groups. I find that even on ward services, we can get it to social determinants. I always ask when I'm making rounds for every patient, how could this admission have been prevented? Just a question. It's invariably a policy issue. Invariably a policy. So we have one woman who was admitted, they called me to the ER to admit her. She didn't need admission. It was the middle of the night. I said, well, give her a taxi voucher. They said, we don't have any more. You don't have any more. So we're going to do $2,000 admission because you don't have $10 for a taxi. Well, what we found out was that the social service group that ran the taxi vouchers needed to save money, so they cut the program. Everyone else got screwed, but they looked good. So we got administration to reestablish the taxi voucher program. There's lots of examples. But what I'm saying is, this stuff is actionable immediately. And for that reason, we wanted to give everyone a skill so that when they ask these questions, it's not just a social worker, it's not just the CHW who knows the answers. Everyone should know this answer. Because if you know the answer, you're going to ask for help when it comes, rather than not knowing, ignore it. So we want to train everybody. Now, there are lots of data points that, as we're kind of building up resources for this. And, some people respond to this, the fact that if all kids can graduate from high school, you'd save as many lives as everyone stopping smoking. We have done a lot of work on the reservations, specifically on trying to get kids to graduate, stay in school, graduate, and then become a health worker of any kind. Because they are much more likely to stay in their home communities or go back to those home communities than almost anyone else. The dilemma is that if you have a Navajo or a Pueblo Indian high school student who really scores well, they're gobbled up immediately by Stanford, Harvard, Dartmouth. They don't come back. So we had to figure out how we're going to do this. And so what we did is we set up, not me, I take credit for other people. No, this is the medical school, under the dean, a BA MD program. So he felt if he could capture young, bright, rural and ethnic minority kids out of high school and guarantee their admission to medical school, they would go through college, but they are guaranteed a place, assume they pass courses, guarantee a place in the medical school. 25% of the admitted class is in this program. Incredible. They've gone through college, but they bonded together. They had these incredible experiences. When you look at the outcome for family medicine, this just came out there, in a good year, 15, 20% will go into family medicine. About. This group, 46%. 46%. It's going on for over a decade. So this is incredible boom to family medicine. And because of this group's participation, the ethnic mix of the school very much reflects that of the state. It's very close now. And that relates to this data. If you look at the ethnic makeup of medical schools, they are not reflecting the community served. There's still a huge gap. The other thing we don't talk about is income. The income of incoming medical students, their families, is shooting up, not their patients. So you have an ethnic disparity and a socioeconomic disparity, which also plays a huge role in who takes care of patients. And newer data is showing all kinds of things. That, this data shows if you're an ethnic minority physician, your chance of seeing a patient of that ethnicity 5 times as high as if you're an Anglo physician. So all of this is the data that keeps pushing us to rethink, how are we doing all of this? So, for example, these health extension agents I showed you, we got them all designated as lecturers. They all have faculty appointments now. And we got that idea from agriculture. Agriculture, when they have an ag agent, they all come in as assistant professors. So they're not discriminating against them because they're in the field doing that thing. So we want to move to that. That was our first step. The other is these diseases of despair. Well, let me get back to this one. Just that from all we've done to try to get graduates into rural and underserved communities, there's an economic argument. This is Dokson's work, I think from Oklahoma. And what they showed is the economic base of any community where you can get a graduate into a rural town is way up. They generate $1 million in business directly, indirectly. They hire 17, 18 people. I mean, it's a big boom. So we don't have to just think of it as a doc and access to care. It's also economic development. And then the diseases of despair. So we got approached by the head of Aging and Long-Term Services, the cabinet secretary under the governor. And I used to work with her when she was in our county. She was the head of behavioral health. But she had a dilemma, and that was they had 18,000 seniors who had called for services, and none of them got a call back from her agency. Why? They have no staff. So they said, could we just call back? Anyway, it was the middle of the pandemic. So our group put together, it was 86 volunteer callers, 86. And most of these were nursing and medical students who couldn't see patients directly because of the pandemic. Now they could talk to patients directly, and we armed them with all kinds of information about how to get people kinds of resources they needed for the aged. Screen. And what they found was loneliness, number one. Really lonely people. And you start thinking of diseases of despair. That was successful, this social determinant kind of thing. Then when the pandemic was really accelerating, they said, could you take that same group of volunteers and shift them over to try to get people vaccinations? Why? Because a sizable minority of people in New Mexico, and probably any state, have barriers. One, they don't have internet. They can't make an appointment. Or they're disabled. Or they don't have a car. They can't drive to a vaccination site. On and on and on. So the same group tooled themselves up to then get all of these people, and they would just call them all around the state to get them vaccinations. Huge. 8,000 got vaccinations by this mechanism. And you can just see, for those they got and set up by phone, all of these vaccination sites around the state. Now, the other thing which we can share, because I've always been an admirer of University of Wisconsin, I think I told, I first came here 60 years ago, 1962. And I used to come here to watch lectures because they were better than the college I was at. And it was great. Anyway, one of the things that became apparent to us doing all the social determinants work at the Health Science Center is that we are not the only active town. If you look at the law school, architecture and planning, engineering, education, business, all of them have a major role to play in social determinants. But they don't think of it that way. They don't work together that way. They have their own courses and lectures. So we put together this hive, health, residency, health, inclusion, vibrancy, equity. But what it really was is finding people from all of the colleges for the whole campus that could come together and talk about social determinants and the role they could play. So this is quite something. We got a request from a veteran who is a prominent state legislator who lives in Silver City. It's way down in the bottom left. And he said when he has to go to the VA and he has to go to the one in Albuquerque, that's his district, for his specialty care, it takes him 18 hours because he has to do a milk run picking up every single vet all the way along the southern part of the state. And then they have to wait till 5 o'clock till the last one is seen, get back on the bus, and they go retrace all the way back. So he said, isn't there anything we can do about this? So I said, transportation? Who the hell does that? I ride a bus. I have a car. So they pointed us to civil engineering. They're the masters of transportation. And they quickly designed a whole system. We haven't gotten it funded yet, but I'm intrigued by it, of a hub and spoke model. In rural New Mexico, the number one health and social problem, is transportation. People can't get anyone, right? And if you're older and your kids have the car, or they moved away, or you don't have good eyesight, you can't drive at night, or you can't go to your senior citizen center, or you can't go shopping. So he designed a system where it was like a hub and spoke model, where you wouldn't focus so much on long drives to Albuquerque, but all of the stuff that happens locally around your town to build local economy, build local resources. He had these cutaways, these small vans that you could put freight, medications, as well as passengers. So I mean, it was so far beyond me. I'm not worthy. This guy's incredible. Then nutrition program on main campus. We got a $250,000 grant to give to our hero who's up in the Shiprock, Navajo area. And they put together a food hub in a very large food desert area. And that hub has taken off. They have refrigeration. They're training local farmers who bring their produce to the food hub, training citizens about nutrition, proper nutrition. It's an amazing, and it keeps growing from that initial investment. The law school invited us over. They said they trained their cadre of clinical law students on earned income tax credit. And I didn't know what they were talking about, but I didn't want to admit my ignorance. I said, really? Very interesting. So we went there, and what they really wanted was, they only have a small number of students. Could we train the community health workers all over the state to get people in need access to these resources? So we said, we don't know what they mean, but it sounds great because the average amount of money is $6,000, $7,000 in someone's pocket like that. And the criteria is you have to be a citizen, you have to have worked for this past year, but you could work for 1 hour. That's it. And then the more kids you have, the more money you can get. And it's not tied to an April tax season. It could be any time during the year. So we trained a whole bunch of, on the basis of what law school taught us, a whole bunch of community, and they've gotten hundreds of thousands of dollars into the pockets of indigent families. It was astounding. So, and then we got a federal grant to study it. So this is my last slide. If you look back, remember that triangle, the hot spot is 5, 10. We're thinking of it differently. In the hospitals and the clinics and the emergency rooms, even when we're doing our very progressive stuff, we're still focusing on the right side, intensive care coordination. We have to figure out a way, as I've shown you examples, of going left, of starting to intervene much, much earlier. But even there is not far enough, because you have to intervene to make sure all kids graduate from high school, people have adequate income, earned income tax credits. So that's the direction we're going in now. And we have to be comprehensive. And there's a lot of wind at our sails with things like the CMS grant. There's headwinds because we're still a fee-for-service system, and that means the hospital is very leery about losing all that money if you're not hospitalizing, paying patients who need procedures. So that's my story. Thank you.